Okay, so our first speaker this morning is Jacques Cohen, who's a renowned embryologist, actually runs our Walter Reed Embryology an IVF clinic at Walter Reed here in the city, and he has practical experience with mitochondria.
Good morning, everyone, and thank you for the introduction, and particularly thank you, committee, for inviting me to speak this morning. We ended with Doug Wallace yesterday afternoon, and because of that, I had to work for another few hours yesterday evening because I felt I needed a little bit of a rebuttal. I've never been in a committee like this where you're invited and you sit and decide and you cannot ask questions or scream or give comments. And I say stop. None of that is possible. I loved the talks yesterday. I loved the debates. All very excellent, really. Dr. Wilfant divided the speakers up according to the Winnie the Pooh characters, Tigger and Eeyore. I'm a Tigger. I just want to go on record that I'm a Tigger. And so I changed my talk a little bit to a different title than I was giving, because I am very optimistic and think that this is a very good plan, but it still needs a bit of work. Here are my disclosures, potential conflicts of interest. I also noticed yesterday that bioethicists don't have conflicts of interest. Basic scientists apparently also don't have conflicts of interest. This is very interesting, so I learned that. I have a few, and they're listed here. The first one is important, and the last one I think is applicable to this particular presentation. The first one, Reprogenetics, is a group based in New Jersey, in various countries, where we perform PGD procedures and PGS procedures for other clinics, in this country, we do PGD for 200 clinics, and I think I needed to disclose this because I will talk a little bit about PGD, and I'll start off my talk on that subject. So is there an alternative to mitochondrial replacement therapy or treatment? Well, I think there is to some extent, and I'll go into that for PGD, and it was mentioned yesterday. What lessons can we learn for MRT from the cytoplasmic transfer series that were performed many years ago now, more than 15 years ago? Cellular stress from micromanipulation is a question that was posed by the committee, and I will cover that, particularly the safety aspects of that. What are the preferred technical approaches? Do you prefer, the question was, do you prefer one of these or all of them or none? And I'll go into that given the time. I may not get to that. And then the nomenclature, which was discussed several times yesterday, so I probably will skip that. And I'll watch these colors, so I won't go too long. So is there an alternative to MRT? There is to some extent. Preimplantation Genetic Diagnosis for transmission of mitochondrial disease is an application that needs serious consideration. It is experimental because this technique has been applied worldwide, estimated less than 50 patients. In general, PGD application varies in clinics in North America from 3 to 85% right now. And the most important reason for that is that the finding over the last 20 years that a very large group of embryos in the lab are chromosomally abnormal. And this is de novo. It's not a transmission from the parent. It happens in all patients, or almost all patients. And it can vary from 0 to 100% in patients, and it's very highly correlated with maternal age. The usage in Europe, and the reason I'm saying this, is that most of the publications on PGD for mitochondrial disease come from Europe. And in Europe, this usage is a lot lower, and they limit most of their procedures to early embryo stages. That is, they take biopsies from early embryos, on day 3, when they are approximately 5 to 8 cells in size. Whereas in North America, the trend has been much more towards blastocyst culture. The culture systems in IVF have changed dramatically over the last 10 years. Things are much better now. And so it's much easier to go to blastocyst with the potential of increasing success rates. Early evidence base shows that it's leaning towards a better outcome with this approach. One advantage of using blastocysts is that they biopsy very well. The human blastocyst has more than 100 cells, usually about 150 to 200 cells. And there are two tissues, trophectoderm and inner cell mass. Inner cell mass, or part of the inner cell mass, will develop into the fetus. The rest of the tissue all becomes placental or extraembryonal. And you can biopsy the trophectoderm, and you can do that even several times. Of course, can't say that this doesn't have an effect on the embryo, but so far, the literature and experiments performed do not show much of an effect on the human blastocyst, but a profound effect on early-stage human embryos. Also needs to be said is that the cryopreservation technology has improved in IVF over the last 10 years, with particularly the application of vitrification, which is an ultra-fast procedure. Results have dramatically increased. So that combination, improved culture, better blastocysts, better cryopreservation, and now the new platforms of genetic testing, such as CGH and SNP arrays and next-generation sequencing, that whole combination has gotten together and has changed the application of PGD and PGS. And so the evidence shows, randomized clinical trials that have been performed so far, and there have not been many, but there have been about 3, and they have not been very large, I must say. Evidence shows that PGS is successful in blastocysts, whereas it also shows that it's not successful in the early stages of development when biopsy is done at the 8-cell stage. So here you see an example of a blastomere biopsy in the bottom right. So that's the early stage of embryo development. And if you wait a few days to day 5 or day 6 of development in the laboratory, the blastocyst is now formed and it gets a little larger, many more cells, and you can take a biopsy out. And as you can see from the right panel, the biopsy is, this biopsy is pretty large, and it's probably about 10, 15 cells. You don't need to do that in each case. You probably do want to do that for an application like this, where you want to show that there is very little variation in the assay, in the result when you assay for the mitochondrial disease. For mutation load. There have been less than 50 cases for this application. As I said, I could be wrong about it because not all these are necessarily published. There are about a dozen papers, less than half about polar body biopsy, and the others are all about blastomere biopsy. It shows that the reliability increases when you take more than one cell out from an embryo. At early stages, it's shown to be detrimental in other work, and so it really isn't a good idea. But it was probably necessary for some of these patients. It's also clear that things go better if you use a more aggressive follicular stimulation and get more embryos. For this application, it's not something I necessarily advocate for IVF patients in general, but it needs to be said that in this particular application, PGD for mitochondrial disease, that may be a good approach. It was shown in several studies that there was little variation in mutation load between the different cells and in the reassays. I'll show you a picture of that. And the conclusion is that my advice would be to do this for mitochondrial disease testing and to consider the blastocysts very strongly, particularly our European colleagues. And combine this with vitrification. Vitrification gives you the advantage that when you freeze the blastocyst, it's now gone and you can do as much testing on those samples as you want and wait for those results. And of course, PGD is aimed at getting a very fast result, usually hours or maybe overnight. But in this case, when you are kind of at the end of in vitro culture, you may want to wait a little longer. And in PGD for mitochondrial disease, you may want to wait really days because you want to reassay the samples to be absolutely sure that the variation in mutation load is minimal. So this is work from a Dutch group. And what you see here in these two panels are 2 attempt cycles. On the bottom you see embryos, so it's a list numbered 1 through 2 in the first attempt and 1 through 4, 5 in the second attempt. And on the vertical axis you see the mutation load. And you can see the green bars, which are the first samples that were obtained. And in repeats, the variations were there, but they were not that strong. So these assays were pretty robust, and this is quite a few years ago, and was done with standard PCR technology. It's imaginable that that kind of technology will improve, and this variation will even diminish further. And of course, there's the red line here, which is the acceptable mutation load, which was a theoretical limit imposed by the clinic, which was set at 15%. Others, for this particular mutation, this is Miles, have put it at 10%. You probably have to be a little bit more conservative, particularly when you have more than 5 or 6 or 10 embryos. You have the luxury of being a bit more conservative. And that is important because in this particular patient, in another patient, in her second cycle, in one of the reanalysis, all these embryos from this patient were considered not appropriate for transfer. But in one of the reanalysis, if you only had this assay available, it looked like that embryo would have been normal. And that's one of the worries people have. But this is just one reanalysis out of about 5 or 6. I think even if this was a lower number for all the analysis, it would have been safe. And so this was a good call. So I do think that that's an application. So what lessons have we learned from cytoplasmic transfer for MRT? Well, we have to go back about 20 years, because in the mid-90s, when we started discussing this, the state of assisted reproduction was dramatically different from what it is today. We thought we had acceptable pregnancy rates, but were still disappointed from day to day, because pregnancy rates were about 20–30% lower than what they are nowadays. And they were achieved by multiple embryo transfers. So a lot of the pregnancies resulted in twin or higher order multiple pregnancies. I remember those days, living in New York City, every other stroller had a twin in it, or a triplet. And that's completely changed now. So single embryo transfer is highly successful because implantation rates per embryo have improved a lot compared to those days. So we wondered in those days, why are these embryos failing left and right, even after egg donation? So in presumably fertile patients, fertile women, why would it fail? And so we wondered about aneuploidy and age, and these were the first years that results were obtained from studying spare human embryos and some patients' embryos where we looked at aneuploidy by fish, just looked at a few chromosomes in one cell and correlated with age, and found that there was a very high correlation. This was not surprising, but we also found that it was quite a bit higher than what we had expected in the base level. Nowadays, we know by looking at all the chromosomes that the average number of abnormal embryos where chromosomes are either too many or there are a few missing, aneuploidy, is about 50% for human IVF embryos. And you can't tell that as an embryologist. You can look through a microscope, you can roll them around, you can look at a different light, you can look at a different microscope, you can't tell them apart. It's only when you do the genetic analysis that you know whether it's aneuploid or not. So we considered that cytoplasmic failure was a distinct possibility. So not only just aneuploidy, because that we had estimated that wouldn't explain all the failures, but there also were failures in the combination of cytoplasm or nuclear interaction, or just cytoplasm, including mitochondria. So that seemed a reasonable proposition at the time, and we decided, after doing some work on mouse embryos, mouse eggs and mouse embryos, and also on spare human material, to select a group of patients with multiple failed IVF, poor embryo development, but not increased maternal age. I need to state that it's not really that important. Every article I read about this, not written by us, states that this was done for advanced maternal age. It wasn't. It was done for repeated IVF failure, and was done because those embryos didn't develop normally. So many of these IVF procedures ended up in no transfer, completely different from what the popular press reports on this. But it even comes across to scientists and clinicians, because Doug Wallace yesterday, this is how he introduced the topic. And he's not the only one, this is just global. I've been trying to correct this every time I talk to anybody about this. It's not working very well so far. So our first 3 patient cycles were done actually with electrofusion, similar to the MRT approach. The settings were very similar to that work. And we found that fertilization was accomplished, and we had embryos and we had some transfers. However, fertilization was not normal. We had a very high rate of activation, meaning that the embryos or the zygotes were formed without a clear interaction with the sperm. And the researchers in Newcastle as well as in Oregon have found that they're exactly the same. You get a high rate of activation, and I see a red flashing light. Is that's correct? Okay. And they found exactly the same. And so we decided not to continue with this, although we had some normal fertilization, that this was probably not correct. And decided to go with ICSI. ICSI is a procedure where you use an injection needle to pick up a sperm and deposit it into the egg for male factor infertility treatment. And why did we want to do ICSI? Because that was a very established approach. At that time, more than 50,000 babies were already born from ICSI, okay? So we felt there were none born from electrofusion, and even today there are no babies born from any electrofusion approach. So we felt that was the approach, and here you see this approach, and that's published. But you see the arrow is actually pointing at the sperm, which is deposited with the cytoplasm at the same time. We performed 37 cycles. There were 17 babies born, 12 deliveries. We found an early exo miscarriage and a late exo termination. At that point, we got concerned. Of course, these were reported to our IRB. They were also reported the first opportunity that we could publish this in 1999. In 2002, it was reported to us that from a male twin in a male-female twin, at 18 months, the child was tested with borderline PDD NOS, pervasive developmental disorder, not of specific origin. We have followed these children up recently. There were also 2 babies confirmed with donor mitochondria in a series of 8, hinting at a heteroplasmy rate of 25%. We call this benign heteroplasmy, and I'm sure the mitochondria experts may not agree with that terminology. This was not mutation-related heteroplasmy. And heteroplasmy is this big bag, and all these terminologies go in there. And heteroplasmy is what everybody is called. So this caused quite a bit of stir, and I wish we had chosen a different terminology. So our first phase follow-up studies started more than a year ago. We're finishing it now. We hope to publish this within 3 to 6 months. And the preliminary data is reassuring, and that includes the baby who was tested for the pervasive disorder. Okay. So why am I referring to this?
Let me ask you something. So just because we're going to have a problem if we start pushing deep into the morning, how many more slides do you have?
Well, I just finished this section and I'm done. Yeah,
okay.
I'll leave the rest.
Good.
Yeah, I'll just finish this. So the reason I'm referring to this work particularly is the comment on heteroplasmy, and that in some animal studies and models, this could be potentially disadvantageous and cause developmental disorders. So there are 2 types of experiments. You can use combinations of 2 inbred species, and that's the common way that this has been tested, not just for cytoplasmic transfer, but for spindle transfer and pronuclear transfer has been tested as well. And the heteroplasmic mice that are born from that are developmentally affected. And the papers, and this is not just the paper from Professor Wallace, these papers show minor to major abnormalities. Now, if you use interstrains, so you use the same strain of mice, or F1 hybrids, there's no effect, or the effects are minor or transient. An inbred, what is an inbred species in the mouse? It's an experiment you would never do in the human, and it's never been done in the human, I think. At least, so you have to have at least 20 consecutive generations of sibling of parent-offspring mating. The Jackson laboratory that supplies most of the laboratories in the United States prides itself in arguing that in their hands it's at least, and the average is more like 40 or 50 generations. So that's an experiment that's never been done in the human, because inbred mice like this are homozygous at virtually all of their loci. Okay, it's not the human model. So we are not an inbred species, and so all of these experiments with inbred mouse strains, I think, are completely irrelevant for this particular application of MRT. And so that's the point I wanted to make. And I can stop at this point. Thank you.
So I'm just trying to figure out, since you're sharing very important information with us, but we also want to make sure we stay on track. That one option would be for Dr. Daly to go now, and we have a discussion with both of you. And maybe you can think about what other take-home messages you would want to share with us that come after this, that we can talk about during the discussion. Oh, okay, so that's where you're going to be.
Well, yeah, so, yeah, I just would make 2 points later.
Okay, hang on one sec. Vamsi, what do you...
If we could continue a little bit longer, I do think that this is pretty important for our committee. I recognize that it might set us off.
I just want to make sure that we make it through everything, obviously.
Yeah, the only points I want to make for MRT and safety aspects are that cytoplasmic transfer was done by intracytoplasmic sperm injection. So ICSI was the mode of delivery. That's a luxury that the MRT specialist people don't have. Well, or maybe they haven't looked at how you deliver a spindle by injection. Maybe that is possible. I think nobody has tried, because the literature is always focused on cytoplast and karyoplast movement between zygotes or cells. It's always done by electrofusion or Sendai virus. So we had the luxury of having more than 50,000 babies were born already from ICSI in 1996 when we started this work. Electrofusion, there's no prior baby born. Sendai Virus Extract, which is something they're looking into now, because I presented our abnormal fertilization results, and 15 years later, in MRT studies in macaques and humans, again, there are abnormal fertilization rates from the use of electrofusion. So the idea is to go to Sendai Virus Extract, which is an older technology, and the use of membrane reluctance, of course, in all of these approaches. The interesting thing about this has been used a lot in larger domestic species and in mice. However, nobody has looked at simple toxicology experiment, dose response curves. How much membrane relaxant do you use? How long for? At what temperature? There's no work done like that. It's probably not sexy enough, so that's why nobody has done it. But that's, I think, is what one should look into in order to improve these technologies and find an optimum. Certainly Dr. Mitalipov has worked towards in that direction. But as basic as this is what I would suggest, that some work needs to be done. And this can be done in the mouse and in spare human material, you know, if that's possible. And then one other point I'd like to make, that there were 2 implantations with Turner syndrome, XO findings after cytoplasmic transfer. Now that is possibly significant, and the reason I say that is you apply statistics to it, it's not that meaningful. But I think that is a reason to worry. And so it is possibly related to cellular stress during the procedure, because we know XO pregnancies or XO embryos can be that the cause can happen exactly at this point, late in meiosis. Late in meiosis 2, you can lose an X chromosome when the second polar body is formed. And so my suggestion would be to do PGS after MRT in all of these cases, preferably at the blastocyst stage, so wait as many days as possible to confirm a normal chromosome set. In work done by the Newcastle group, it was shown that chromosomes were normal in spare embryos. However, that's different from the clinical practice. In the clinical practice, I do think you have to confirm this in the hope that you can avoid abnormal chromosome embryo transfer. That first of all, and that will be a good subset of the embryos that are available after the initial assays are done. So it will dilute the number of embryos available. But I think that is for the better, and that's the only point I'd like to make. Thank you.
Thank you. Let's just go to George. Yeah. Go ahead. Whoever's introducing.